Teleophthalmology for Rural and Underserved Populations, August 2026 Outcomes Trial. Evidence Snapshot, August 19, 2026. Teleophthalmology can bring retinal imaging, optical coherence tomography, visual acuity testing, eye pressure measurement, specialist review, care navigation, and referral coordination closer to where patients live. This is especially important in rural communities, federally qualified health centers, Indigenous communities, and low-income areas where travel distance, cost, limited transportation, and shortages of ophthalmologists can delay care. However, an important evidence limitation should be stated clearly. I could not verify a single completed August 2026 randomized or stepped-wedge trial that enrolled rural or underserved patients and followed glaucoma, diabetic retinopathy, and age-related macular degeneration from screening through treatment initiation, while also measuring vision outcomes, preventable complications, costs, and satisfaction. Reporting such a trial as if it existed would require inventing results. The available evidence is therefore best understood as a 2026 evidence set made up of several complementary trials and programs. Together, these studies show that teleophthalmology can improve screening participation, reduce unnecessary urgent referrals, shorten specialist waiting times, and achieve high patient satisfaction. They also show that the strongest remaining weakness is the last mile between a positive screen and completed treatment. Key findings. The strongest completed end-to-end randomized evidence comes from the United Kingdom Community Optometry Trial, known as the Hermes Study. Teleophthalmology reduced unnecessary urgent referrals and shortened the average time to specialist consultation from 89 days to 53 days. The same trial showed a clinically shorter average time from the initial community visit to treatment, 55 days compared with 90 days, although the difference was not statistically significant. In the Michigan Screening and Intervention for Glaucoma and Eye Health through Telemedicine study, 99% of participants were satisfied or very satisfied, and the program cost approximately $110.99 per participant served. In rural Alabama, teleophthalmology detected substantial levels of glaucoma-related disease and diabetic retinopathy. Among referred participants in the initial Alabama cohort, 76.7% attended follow-up, including 92% of those referred for glaucoma. Randomized diabetic retinopathy evidence shows that telemedicine can substantially increase completion of screening, but available trials have not directly quantified the number of cases of blindness prevented. Randomized age-related macular degeneration evidence suggests that teleophthalmology can identify new suspected disease without worsening visual outcomes. But remote monitoring of recurrence may delay treatment unless the pathway includes rapid escalation. A sustainable model requires local imaging staff, remote eye specialists, care navigators, local treatment partners, interoperable electronic health records, and strong cybersecurity controls. What the available trials actually tested. For the full table, please open this article on visualfieldtest.com. The United Kingdom Hermes trial is the closest match to a complete referral pathway. The rural American studies are more relevant to health equity and community implementation, but they generally functioned as screening plus navigation programs rather than randomized comparisons of screening through treatment. Effects on time to diagnosis and treatment. The strongest evidence, faster specialist consultation. In the United Kingdom cluster randomized trial, patients referred through a teleophthalmology pathway reached hospital consultation faster than patients using standard referral. Teleophthalmology pathway, approximately 53 days. Standard pathway, approximately 89 days. Difference, approximately 36 days faster. For urgent referrals, the average time to consultation was approximately 23 days with teleophthalmology versus 53 days with standard referral. The pathway also shortened the average time from the initial community optometry visit to treatment from approximately 90 days to 55 days, although the treatment difference did not reach statistical significance. The trial also found that 62 participants required treatment. Among those who attended consultation, treatment was required in 55.2% of teleophthalmology participants compared with 28.9% of standard care participants. This does not mean teleophthalmology caused more disease. It more likely indicates that remote specialist triage directed a greater proportion of appropriate patients toward specialist care while reducing unnecessary visits. Diabetic retinopathy, better screening access, incomplete time to treatment evidence. The Tribal Vision Project randomized 567 participants and found that telemedicine greatly increased the likelihood of completing diabetic retinopathy screening. Within 6 months, 94.6% with telemedicine versus 43.9% with traditional surveillance. Between more than 6 and 18 months, 53.0% versus 33.2%. Over approximately 4 years, diabetic retinopathy worsened by at least 2 stages in 8.5% of participants and improved by at least 2 stages in 1.2%. Overall, disease severity remained generally stable. However, the study did not provide a definitive estimate of how many cases of severe visual loss or blindness were prevented through telemedicine. A 2026 stepped-wedge randomized quality improvement trial involving 5,665 adults with type 2 diabetes found that electronic health record bulk orders increased the odds of completing diabetic retinopathy screening by approximately 78%. The 6-month completion rate was 17.5%, and the median time from the bulk order to a retinal imaging appointment was 79 days. This result shows that teleophthalmology infrastructure alone is not enough. Scheduling access and patient follow-through remain major bottlenecks. Age-related macular degeneration. Initial referral was comparable. Recurrence monitoring required caution. In a randomized clinical trial of teleophthalmology for suspected neovascular age-related macular degeneration, referral to diagnostic imaging took 22.5 days with teleophthalmology versus 18.0 days with routine care. Diagnostic imaging to treatment took 16.4 days versus 11.6 days. Neither difference was statistically significant. For recurrence monitoring, treatment reinitiation took approximately 13.6 days with teleophthalmology versus almost immediate treatment in the routine group. Despite the delay in recurrence treatment, there was no difference in final visual acuity. These results support teleophthalmology for initial triage when there is a reliable escalation system. They also warn against allowing remote monitoring to become a passive process. Patients with suspected recurrence need rapid clinical review and, when necessary, immediate injection scheduling. Outcomes by eye disease, glaucoma. Glaucoma is particularly challenging for teleophthalmology because diagnosis and treatment usually require more than a photograph. A useful pathway may include visual acuity measurement, intraocular pressure, central corneal thickness, optic nerve photographs, optical coherence tomography of the retinal nerve fiber layer, visual field testing when feasible, medical and family history, remote specialist review, in-person confirmation and treatment planning. The Michigan Community Program identified glaucoma or suspected glaucoma in 22.4% of 3,709 participants. It identified diabetic retinopathy in 4.7% and macular degeneration in 1.7%. Among participants who screened positive for glaucoma or suspected glaucoma and were randomized to receive either written education or personalized education with health coaching, follow-up attendance was similar, 61% versus 59%. In the 3 screening and intervention for glaucoma and eye health through telemedicine sites, glaucoma or suspected glaucoma was detected in 18.6% of Alabama participants, 24.0% of Michigan participants, 26.7% of New York City participants. In-office referral rates were 47.3% in Alabama, 42.8% in Michigan, and 66.1% in New York City. The variation partly reflects differences in screening equipment, referral criteria, and whether refractive error was treated locally or referred elsewhere. The Michigan program also reported modest improvement in presenting visual acuity among the 943 participants who returned for repeat screening. Worse eye visual acuity improved from a mean logarithm of the minimum angle of resolution value of 0.25 to 0.21, while vision-related quality of life improved from 81.1 to 86.4. These findings are encouraging, but the repeat screening group was not a randomized sample, and many participants received glasses or other care. The results, therefore, cannot be interpreted as proof that teleophthalmology prevented glaucoma progression. What remains unproven in glaucoma? No completed rural randomized trial identified in this evidence review demonstrated reductions in visual field loss, glaucoma progression, emergency glaucoma surgery, medication failure, irreversible blindness. Teleophthalmology appears effective for case finding and referral, but a definitive glaucoma outcomes trial must measure whether patients actually start pressure-lowering treatment and preserve visual fields over at least 2 to 3 years. Diabetic retinopathy. Diabetic retinopathy is currently the disease with the strongest evidence base for teleophthalmology. Remote retinal imaging can be integrated into primary care, diabetes clinics, pharmacies, mobile units, or community health centers. The major benefits are more patients screened, earlier identification of referable disease, fewer unnecessary routine eye visits, better use of specialist capacity, potentially earlier treatment for diabetic macular edema and proliferative disease. A statewide safety net network in Kentucky found that, among adequate examinations, 22.0% showed some diabetic retinopathy, 15.2% required specialist referral, and 7.7% required referral for other eye conditions. The study also found that continuity of screening increased the likelihood of detecting referable disease. These findings are observational rather than randomized, but they illustrate why teleophthalmology can identify more than diabetic retinopathy alone. The major weakness is that screening completion does not automatically equal treatment completion. A patient with sight-threatening diabetic retinopathy may still fail to attend a retina appointment because of transportation problems, work obligations, cost, fear of injections, language barriers, or lack of understanding. Age-related macular degeneration. Age-related macular degeneration requires a different pathway from diabetic retinopathy. Screening should distinguish no disease, early or intermediate dry disease, geographic atrophy, suspected or active neovascular disease, stable disease requiring monitoring, recurrence requiring prompt treatment. Fundus photography can identify drusen and macular changes, but optical coherence tomography is particularly important when fluid or neovascular disease is suspected. The United Kingdom Hermes trial found that teleophthalmology improved the accuracy of referrals for suspected neovascular age-related macular degeneration. In that trial, the intervention pathway had approximately 90.9% sensitivity and 100% specificity for neovascular age-related macular degeneration referrals, compared with approximately 57.9% sensitivity and 88.9% specificity in standard care. For age-related macular degeneration, teleophthalmology should therefore be viewed as a triage and monitoring system, not as a substitute for retinal treatment. Active disease still requires an appropriately trained clinician and access to antivascular endothelial growth factor treatment. Preventable complications: what was and was not demonstrated. The available trials support improvements in process measures, but evidence for reduced preventable complications remains incomplete. Demonstrated or strongly supported benefits: fewer unnecessary urgent referrals, faster specialist consultation, higher diabetic retinopathy screening completion, better identification of glaucoma-related disease in underserved populations, high patient acceptance, stable diabetic retinopathy severity over long-term follow-up. No demonstrated visual harm in the randomized initial age-related macular degeneration referral pathway. The Hermes trial reduced false positive urgent referrals from 18% with standard care to 1% with teleophthalmology among all enrolled participants. Among referred participants, false positive urgent referrals fell from 63% to 4%. The trial did not find a significant difference in false negative referral safety, not yet adequately demonstrated. The evidence does not yet provide a reliable randomized estimate of blindness prevented glaucoma visual field loss, prevented diabetic macular edema, treated before vision loss, proliferative diabetic retinopathy complications avoided, retinal detachment or vitreous hemorrhage avoided, vision maintained after age-related macular degeneration treatment, long-term treatment adherence across multiple diseases. A future rural outcomes trial should therefore avoid using screening completion as its only success measure. It should follow each abnormal screen through confirmed diagnosis, treatment initiation, treatment adherence, and visual outcome. Cost effectiveness. Compared with standard referral. United Kingdom randomized evidence. The Hermes economic evaluation found that the teleophthalmology pathway was dominant over standard referral, meaning it produced greater effectiveness at lower modeled cost. Expected cost per case with standard care, approximately £183. Expected cost per case with teleophthalmology, approximately £167. Estimated saving, approximately £16 per case. Estimated net benefit when patient preferences for diagnostic accuracy and shorter waiting times were included, approximately £992 per patient. These results came from a United Kingdom health system perspective and should not be directly converted into United States costs. They do, however, demonstrate the economic logic of reducing unnecessary hospital visits while directing specialist time toward patients who actually need treatment. Community program costs in the United States. The Michigan program cost approximately $110.99 per participant, served $206.72 per case of eye disease detected. Those figures included community-based screening, remote interpretation, navigation, and associated program operations. They were not a head-to-head comparison with standard referral, so they should not be interpreted as proof that the program was cheaper than usual care. A separate 2026 Spanish analysis of the Quixote Teleophthalmology program found a direct cost of approximately 22.47 cents per patient, compared with 32.50 for face-to-face care. The program also reduced mean waiting time from 89 days to 39 days. Because this was a retrospective observational analysis rather than a randomized trial, it is supportive implementation evidence rather than definitive comparative evidence. Patient costs matter. A proper rural cost-effectiveness analysis should include more than the health system bill. It should also measure fuel, taxi, or public transportation, lost wages, childcare, companion travel, hotel stays for distant specialty appointments, missed work caused by multiple visits, the financial impact of delayed treatment. A rural teleophthalmology network in India estimated savings of approximately 80 kilometers of travel and $4.60 in travel costs per patient in its primary rural network. The amount may appear small, but the value can be substantial when multiplied across thousands of patients and combined with avoided lost wages. Patient satisfaction and trust. Patient satisfaction was generally high in community-based teleophthalmology programs. Michigan, 99% satisfied or very satisfied. Rural Alabama, 85.8% very satisfied with the screening. Rural Alabama, 83.2% very satisfied with the time required. Rural Alabama, 92.2% considered screening in the primary care clinic very convenient. Rural Alabama, 95.4% were very likely to recommend screening. However, satisfaction alone does not prove clinical effectiveness. Patients can like a convenient service while still failing to attend a needed treatment appointment. The most successful programs combine screening with immediate explanation of results, care navigation, transportation support, and appointment scheduling before the patient leaves the community site. In the age-related macular degeneration randomized trial, satisfaction was high in both teleophthalmology and routine care groups. There was no meaningful difference in ease of access, registration, staff friendliness, or overall appointment convenience, although the teleophthalmology group reported greater satisfaction with parking. Qualitative work linked to the United Kingdom trial found that patients and clinicians valued shorter travel and better referral efficiency. At the same time, patients wanted clear explanations of why they were or were not being sent to the hospital. Delayed or incomplete feedback reduced confidence in the system. Data security for rural teleophthalmology. A rural program may use retinal cameras, optical coherence tomography devices, mobile tablets, cloud platforms, electronic health records, text messages, and remote specialist workstations. Each connection creates a possible point of failure. In the United States, the Health Insurance Portability and Accountability Act security rule requires appropriate administrative, physical, and technical safeguards to protect the confidentiality, integrity, and availability of electronic protected health information. The Department of Health and Human Services also emphasizes risk analysis, backup planning, recovery procedures, and protection during emergency operations. A sustainable teleophthalmology program should include essential technical safeguards, encryption during transmission and while stored, multi-factor authentication for staff and specialists, role-based access so staff see only the information needed for their work, automatic locking of cameras, tablets, and workstations, audit logs showing who viewed, changed, or transmitted patient data. Regular software updates and security patches. Separate networks for medical devices and general guest internet access. Secure backup and downtime procedures. A documented breach response plan. Business associate agreements with cloud and platform vendors. The Food and Drug Administration emphasizes that connected medical devices require cybersecurity management throughout their entire life cycle, including design, deployment, maintenance, vulnerability response, and retirement. Patient-facing privacy practices. Patients should be told what information is collected, where images are stored, who reviews them, whether an automated system is used, how long records are retained, what happens if the internet or system fails, how to request correction of an error, how to contact the program about a privacy concern. Security protections should not be hidden in technical language. Trust is especially important in communities that have experienced discrimination, poor access, or previous breaches of personal information. Interoperability, making the pathway, follow the patient. Teleophthalmology fails when the image reaches the remote specialist, but the result never returns to the primary care team or the patient's treatment clinician. The Office of the National Coordinator for Health Information Technology identifies Health Level 7 Fast Healthcare Interoperability Resources as a major standard for exchanging structured health information. Fast Healthcare Interoperability Resources allows systems to exchange separate data elements, such as observations, diagnoses, referrals, appointments, and care plans, rather than sending only an unsearchable document. The pathway should also support digital imaging and communications in medicine for retinal photographs and optical coherence tomography images. The Food and Drug Administration describes medical device interoperability as the ability of devices and systems to exchange and safely use information for display, storage, interpretation, and analysis. A closed-loop teleophthalmology referral should automatically transmit patient identity and contact information, symptoms and symptom onset, visual acuity, intraocular pressure, imaging and image quality status, remote specialist diagnosis, referral urgency, recommended clinician appointment date, treatment initiation status, missed appointment alerts, follow-up interval. Programs should avoid relying on scanned paper forms or isolated PDF reports. A patient with suspected proliferative diabetic retinopathy or active neovascular age-related macular degeneration should not disappear into a referral queue simply because two systems cannot exchange structured information. Staffing models for long-term sustainability. The most practical model, local capture, remote interpretation, local navigation. The evidence supports a hub-and-spoke model, local community team. A trained ophthalmic technician, nurse, medical assistant, or community health worker performs registration and consent, medical and eye history, visual acuity, intraocular pressure measurement, retinal photography, optical coherence tomography when available, visual field testing when appropriate. Patient education, remote specialist team, an ophthalmologist, optometrist, or trained reading center clinician, reviews image quality, interprets the screening data, assigns urgency, identifies patients requiring in-person examination, communicates a clear plan, escalates urgent findings. Care navigator. A dedicated navigator should explain the result in plain language, schedule the next appointment, arrange transportation, confirm insurance or financial assistance, send reminders, track missed appointments, confirm treatment initiation, report unresolved referrals back to the primary care team. The Michigan program used ophthalmic technicians to collect clinical information and imaging, with remote ophthalmologists making recommendations that were communicated locally. The Alabama program similarly used remote ophthalmologist review and tracked whether patients completed in-person follow-up. Disease-specific treatment partners. One clinician cannot manage every condition remotely. Glaucoma. Local optometrist or ophthalmologist for confirmation, medication initiation, and pressure monitoring. Glaucoma specialist for complex disease. Diabetic retinopathy. Primary care and diabetes teams for systemic risk reduction. Retina specialist for diabetic macular edema, proliferative disease, laser treatment or injections. Age-related macular degeneration. Retinal specialist or injection-capable ophthalmologist for suspected active neovascular disease and recurrence. Workforce sustainability. The rural implementation for sustained impact in teleophthalmology trial is designed to test coaching, technical assistance, workflow support, follow-up, and implementation costs across rural health systems. It is important because many programs fail not from poor image quality, but from inadequate workflow integration, staffing, reimbursement, and referral capacity. As of August 19, 2026, the registry describes the trial as an implementation study rather than a completed outcomes report. Sustainable programs should also provide standardized training and annual competency checks, backup staff for illness and turnover, image quality review, a clear process for ungradable images, protected specialist reading time, payment for image acquisition and remote interpretation, equipment replacement budgets, referral agreements with nearby treatment providers, monthly monitoring of time to diagnosis and treatment, equity monitoring by race, language, insurance, disability, and rural distance. What a definitive rural August 2026 outcomes trial should measure. The next major trial should use a cluster randomized or stepped-wedge design across rural primary care clinics, mobile units, tribal health centers, and federally qualified health centers. Primary outcomes: time from screening to confirmed diagnosis, time from positive diagnosis to treatment initiation. Vision-threatening complications: best corrected visual acuity, visual field change for glaucoma, diabetic retinopathy progression, macular fluid or lesion progression, treatment completion and follow-up adherence. Secondary outcomes: cost per case detected, cost per quality adjusted life year gained, patient travel distance and lost work, patient satisfaction, trust and perceived privacy, image quality failure rate, specialist, workload, staff turnover, referral completion, treatment completion, equity of outcomes across patient groups. The trial should compare standard referral with a complete pathway that includes imaging, remote specialist review, patient navigation, transportation support, electronic scheduling, and confirmation that treatment actually began. Conclusion: by August 2026, the evidence supports teleophthalmology as a practical way to expand access to eye care in rural and underserved communities. The clearest benefits are higher diabetic retinopathy screening participation, strong detection of glaucoma-related disease, fewer unnecessary urgent retinal referrals, shorter specialist waiting times, and high patient satisfaction. The evidence is less definitive for the outcomes that matter most to patients: fewer cases of irreversible vision loss, faster treatment initiation across all three diseases, and long-term preservation of vision. Existing studies often stop at screening or referral. The next generation of trials must follow patients through diagnosis, treatment, and visual outcomes. The most sustainable model is not a technology-only service. It is a coordinated system in which local staff capture high-quality data, remote specialists interpret it, navigators close the referral loop, local clinicians provide ongoing care, and secure interoperable systems allow information to follow the patient. All links to sources are available in the text version of this article. You can find the full article at visualfieldtest.com. Thanks for listening. To check your visual field, click the link at the bottom of this article or visit visualfieldtest.com.